Welcome. In this lecture, we'll be discussing Myasthenia Gravis and Lambert-Eaton Syndrome. To truly understand these pathologies, we must first discuss the normal mechanism of the NMJ. In this diagram up here, we will have the presynaptic space, and down here where it says muscle fiber will be our postsynaptic terminal. So what happens first is that you get some sort of action potential or nerve impulse that travels down a motor neuron to the presynaptic terminal at the NMJ. This action potential opens voltage-gated calcium channels, allowing calcium to enter into the synaptic cleft. This calcium triggers synaptic vesicles to fuse with the membrane, releasing acetylcholine into the synaptic cleft. So the release of calcium will then help trigger the release of acetylcholine. This acetylcholine diffuses across the cleft and binds to nicotinic postsynaptic receptors seen here. This leads to some sort of depolarization via allowing sodium into the cells and potassium out, which then causes a muscle action potential and in turn a contraction. This ends with breaking down the acetylcholine by an enzyme known as acetylcholinesterase, which rapidly breaks down acetylcholine in the cleft, terminating the signal. Understanding these 7 steps is important to understand both of these diseases, especially number 3 and number 4. So let's first discuss the pathology of myasthenia. Myasthenia is an autoimmune disorder where autoantibodies are directed against some sort of protein located at that NMJ that we just talked about. Without a doubt, the most common is going to be your nicotinic postsynaptic acetylcholine receptor. Understand that is in the nicotinic receptors. There's 2 primary receptors, muscarinic and nicotinic. For MG, we're primarily affecting the nicotinic. This makes up about 85% of all NMJs. Other types can be muscle-specific kinase, also known as MuSK, which is seen in roughly 5% of cases. Myasthenia is a type 2 hypersensitivity reaction in which the antibodies stick to the receptor. So here's our diagram depicting the pathology. Down here are our nicotinic acetylcholine receptors. What occurs is that the antibodies located here bind and in turn compete with acetylcholine. Thus, when I want to initiate some sort of contraction, that is going to cause calcium to release acetylcholine into the cleft, but those receptors on the postsynaptic side could or might already be bound by these acetylcholine receptor antibodies. Thus, it decreases the likelihood of some sort of depolarization to occur, which leads to weakness. Now, myasthenia has a bimodal distribution, typically seen in young females, less than 40, with peak age onset of 20 to 30 years old, and males greater than 50, typically seen in males between 60 to 70 years old. There are 2 risk factors that you should know for MG. HLA-B8 is one of them. The human leukocyte antigen system helps the immune system distinguish self from non-self. So the HLA-B8 system doesn't directly cause myasthenia gravis, but it increases the risk by influencing how the immune system recognizes self-antigens. Thus, having an issue with HLA-B8 can cause an exacerbation or cause an individual to recognize its self-antigens, leading to a breakthrough of MG. Medications can also cause myasthenia. The big one that you want to know is aminoglycosides, which typically end in CIN or SYN. These are absolute contraindications. The reason being is because aminoglycosides inhibit the calcium influx, which in turn decrease the amount of acetylcholine that I release. This can weaken the neuromuscular transmission, resulting in a neuromuscular blockade. Now, other medications that you can also know is penicillamine, which can cause MG de novo by autoimmune mechanisms, and certain types of fluoroquinolones. But without a doubt, the most commonly tested are going to be your aminoglycosides, which are absolutely contraindicated in people with MG. So what symptoms do we see in MG? The most common symptom that we're going to have is this fluctuating weakness that worsens with movement. It is worse at the end of the day. The reason being is because as you contract or you try to contract your muscles, you're going to lead to release of more acetylcholine. Eventually, you're going to run out of acetylcholine. Thus, there's going to be less acetylcholine to bind to those already bound receptors. Thus, you get weakness at the end of the day. The most common symptoms that we're going to see is ptosis, eye droopiness, and diplopia, or double vision. You'll also get bulbar symptoms. These bulbar symptoms occur due to use of the muscles, dysarthria, trouble speaking, fatigable chewing, dysphagia. This typically occurs as an individual speaks more or eats, etc. Now, big distinguishing factors between MG and Lambert-Eaton syndrome is that MG, the reflexes are intact. This can also be compared to Guillain-Barré syndrome, which is talked about in another lecture, in which the reflexes are absent. There are also no autonomic issues such as dry mouth, dry eyes, or orthostatic hypotension, which can be seen in Lambert-Eaton syndrome. Thus, your classic presentation is going to be a young female or an old male who comes in due to feeling weak at the end of the day. They have trouble keeping their eyes open, they have double vision, and they feel that when they eat meals, they have weak chewing, weak jaws, trouble swallowing, something along those lines. Now, there are some physical exam maneuvers that you are supposed to be responsible for to know for test day. The most commonly tested, and the still one used in practice, is going to be the ice pack test. The placing ice over the eye improves symptoms, typically ptosis. The ice pack test improves ptosis in MG because cooling inhibits that acetylcholinesterase enzyme. That's the enzyme that breaks down the acetylcholine. Thus, if we inhibit it, we allow the acetylcholine to sit in that synaptic cleft for even longer. This allows for increased availability of ACH, more likelihood for them to bind to the receptors, more likelihood for improvement of symptoms due to some sort of action potential. The way that I've always remembered this is with the mnemonic ICE. ICE stands for inhibits cholinesterase, aka inhibits acetylcholinesterase, and E enhances acetylcholine. So placing ICE in MG inhibits ACH, or cholinesterase, and enhances the amount of acetylcholine that we have. Now, another type of mechanism that really isn't used too much anymore is the edrophonium test. This is also an acetylcholinesterase inhibitor, typically with a short duration. This is only used in patients with ptosis. Now, this increases the amount of acetylcholine in the synaptic cleft by doing a very similar mechanism by inhibiting that acetylcholinesterase enzyme. This improves symptoms. This may result in false positives and cause life-threatening bradycardia, and due to that, this is rarely used anymore. I've included here for completeness sake, but if you see this on the test, most likely this will not be the answer choice because this is no longer commonly used or practiced. Now, how exactly do we diagnose MG? This typically goes in a stepwise pattern. The first step that we always get is we always start with the acetylcholine receptor antibodies. Remember, that is the most common autoantibodies that are being produced. Once this comes back positive, the MG is going to be confirmed via an EMG. The EMG confirms MG by showing a decrease in amplitude on repeated stimulation. Remember, you get weaker the more you move. That's how all the symptoms occur, and that's why you get weaker or you feel more tired at the end of the day. Thus, as we contract those muscles, because we run out of acetylcholine, our amplitude on EMG should be decreasing. You'll see that the opposite will be true in Lambert-Eaton syndrome. Now, what exactly is the treatment for MG? Well, the treatment's going to be an enzyme known as pyrogistamine, which is an acetylcholine esterase inhibitor. I've always remembered pyrogistamines for MG because it helps me get rid of myasthenia. This increases how long acetylcholine remains in the synaptic cleft. Now, many individuals know this. Thus, the questions that might be asked about pyrogistamine may be associated with its adverse effects. A mnemonic to help remind you of what the adverse effects are is sludge. Salivation, lacrimation, urination, diaphoresis, GI, and emesis. It essentially makes everything run. It makes everything watery. Watery eyes, vomiting, diarrhea. That is what acetylcholinesterase inhibitors do. Understand the adverse effect and understand that pyrogistamine is first line. Now, if pyrogistamine does not help, then there are second line agents, typically immunotherapy agents. This will be either corticosteroids, azathioprine. This is used in MG because the disease is caused by an autoimmune attack, most commonly on that acetylcholine receptor, sometimes MuSK as well. Immunotherapy works by suppressing or modulating the immune system, reducing autoantibody production, decreasing inflammation, preventing further destruction of the NMJ. Thus, typically we start with pyrogistamine to get rid of MG, But if that does not work, then we can try immunotherapy as well. Now, there are two big complications that you want to know for MG. Thymoma will be the most commonly tested. This is actually only seen in 10 to 15% of people with MG, but there is some sort of thymic issue or thymic change in roughly 70 to 80% of people. Thus, everyone who gets diagnosed with MG, regardless if they have symptoms or not, get a CT or MRI of the thymus. Why do we do this? Well, we're looking for an enlarged thymus or a thymoma, which is demonstrated here, outlined in red in this image. This helps to depict treatment. If a thymoma is present, whether or not you have MG or not, a thymectomy is going to be done. The reason being is because this is associated with increased remission rates in patients with MG. Thus, if a thymoma is found, we typically are going to remove it, and if they have MG, then most likely that will help to put into remission. This is extremely high yield to know for test day. The other complication that can arise is something known as myasthenia gravis. This is when you get respiratory weakness secondary to MG. Remember, this causes weakness of muscles, typically affecting the bulbar muscles, the ocular muscles, but very close to that is going to be your respiratory muscles as well, your scalenes, your trapezoids, your intercostals, all those which help you to breathe. Thus, individuals with myasthenia gravis will either have a history of MG or have baseline symptoms of MG and then have signs of respiratory distress, such as increased respiration rate, shallow breathing, trouble getting air in, new O2 requirement, tachycardia, respiratory muscle usage. This is also important to know because myasthenia gravis crisis is going to be treated typically with IVIG or plasmapheresis. That is the gold standard or the medications that they're going to test you on. Obviously, with MG or myasthenia gravis, you also want to pay attention to the ABCs. Some individuals will require steroids. We typically look for underlying causes, which may be causing stress on the body to cause these symptoms. And of course, do these individuals need to be intubated or not? A mnemonic to help remember this is known as crisis, where C stands for check respirations, R for respiratory support, such as intubation, I will be for IVIG or plasmapheresis, S steroids, I is to look for the triggers that can cause this, and then S is we stop those cholinesterase, that pyrogistamine, if an individual is intubated. Now that concludes myasthenia, but let's now discuss what is typically tested against, Lambert-Eaton syndrome. This is an autoantibody directed against the presynaptic calcium channels, where MG is against the postsynaptic acetylcholine receptors. This leads to decreased release of acetylcholine into the neuromuscular junction. Remember, calcium needs to be influxed into the synaptic cleft in order to release acetylcholine. No acetylcholine, no muscle movement. This is highly associated with paraneoplastic syndromes. In roughly 50 to 60% of the time, we see that. Other causes can be idiopathic, like autoimmune, but usually Lambert-Eaton syndrome is caused by something else. It is high yield to know that the most commonly associated cause is going to be small cell lung cancer. Thus, on test day, either look for individuals with small cell lung cancer or look for signs that predisposes risk factors for small cell lung cancer. Here's our normal neuromuscular junction. If we have autoantibodies against the presynaptic calcium channels, we can no longer release calcium into the synaptic cleft. This means that acetylcholine can no longer be released into the synaptic cleft, and there is no more contraction. Thus, this leads to weakness in some way, shape, or form. Now, the symptoms are going to be very opposite of MG. This will be symmetrical proximal muscle weakness that improves with contraction. Compared to MG, it's opposite. This is better at the end of the day. Why is that? Well, remember, not every single muscle fiber, every single presynaptic channel is going to be affected. Thus, as I try to do a muscle contraction, more and more calcium is going to be released. That's going to allow it to be easier to release acetylcholine and thus cause some sort of action potential or contraction. Thus, over contracting muscles will lead to easier ability to cause contractions. It improves as you use it because of increased calcium release. You'll also see autonomic issues, typically dry mouth, dry eyes, or orthostatic hypotension. This is opposite and unique of Lambert-Eaton syndrome. You will see no reflexes. This is opposite of MG. Remember, in MG, you will have reflexes intact. Other things that can point you towards Lambert-Eaton syndrome can be cranial nerves. Ptosis and diplopia are very commonly put in these question stems to help confuse you, because this is seen in both Lambert-Eaton syndrome as well as MG. But look for other things such as signs of malignancy in individuals older age, lung nodule, smoker, weight loss, cachectic, shortness of breath, dyspnea on exertion. All of these are screaming at you some sort of lung cancer in the setting of proximal muscle weakness is most likely Lambert-Eaton syndrome. It is also important to know that this does not respond to that ice pack test or the adrophonium test or challenge. The reason being is because these tests are going to compete with acetylcholine or acetylcholinesterase. That inhibits or slows down acetylcholinesterase, allowing the acetylcholine to remain in the synaptic cleft for longer. The issue with Lambert-Eaton syndrome is that we're not even producing or releasing calcium. Thus, acetylcholine is not in our synaptic clefts to begin with. Thus, these individuals do not respond to this ice pack test. Now, how exactly do we diagnose Lambert-Eaton syndrome? Well, this is typically a clinical diagnosis. There are some things that we can do to confirm as well as to help guide us in the right direction. Typically, EMG confirms the diagnosis, similarly to MG, and opposite of myasthenia, in which we have decreased amplitudes with contraction, here we're going to have increased amplitude or improvement of amplitudes with contraction, for the same reason that more calcium is being released, causing more acetylcholine to be released, causing more action potentials. About 85 to 90% of patients will have antibodies to the 2-volt engaged calcium channels. But for the most part, this is going to be a clinical diagnosis because it has a very unique presentation and it is typically associated with some sort of underlying issue, most commonly small cell lung cancer. And for that reason, people with Lambert-Eaton syndrome should get a CT chest for cancer screening. Now, the treatment is going to be very straightforward. Because of the fact that this is going to be associated with some sort of underlying cause, the treatment is going to be to correct that underlying cause. Small cell lung cancer, typically treated with chemotherapy. If you were to have to choose a medication, your first line medication would be amifampridine. And the reason it's this medication that I cannot pronounce is because this increases the presynaptic calcium influx. And when we increase that calcium influx, what are we doing? We're increasing acetylcholine release and thus causing more action potentials to be generated. Now here is a table comparing myasthenia and Lambert-Eaton syndrome. What I want you to take away from this is that essentially, if you know the symptoms, the labs for one of them, you should understand that the other one is pretty much going to be the complete polar opposite. Example, EMG for myasthenia is going to get worse or decrease amplitude with use. EMG for Lambert-Eaton is going to get improved or increase amplitude with use. This is going to have muscle weakness. MG is going to have muscle weakness worse with use. Lambert-Eaton syndrome is going to have muscle weakness improved with use. They are opposites in that sense. This is just to simplify things. Now let's quickly do 2 practice questions. Take your time, pause the video, and answer this question to the best of your ability. The correct answer to this question is going to be answer choice D. This is highly associated with small cell lung cancer. This is because what is being described here is going to be Lambert-Eaton syndrome. It is asking us to compare how this changes or differs from myasthenia, and we should understand that Lambert-Eaton syndrome is highly associated with small cell lung cancer. Pause the video, take your time, and answer this question. The correct answer to this question is going to be choice B. This patient is in myasthenia crisis, a life-threatening exacerbation of MG. This is characterized by its respiratory muscle weakness. This required intubation, mechanical ventilation. So after the airway is stabilized, those ABCs are done, the next step is to rapidly reduce the circulating antibodies. This is done using plasmapheresis or IVIG. It is important to know that both are equally effective and chosen based on the availability and specific factors per patient. You should not have to worry about that on test day. And this concludes this lecture on myasthenia gravis and Lambert-Eaton syndrome.